Welcome back to Care Anywhere. On this From the Bench episode, we're addressing a globally critical issue, safe staffing. For too long, the conversation has focused on shortage alone. And while growing the workforce is critical, none of us would argue that. It's not enough. Safe staffing is not just about numbers. It's about how care is actually delivered. Our new report, Safe Staffing Through New Models of Care, brings together global health leaders to outline a different path forward, one that's grounded in team based interprofessional care, enabling clinicians to practice at the full scope of their training, integrating technology in ways that support rather than replace human care, and designing systems that are sustainable for both patients and the workforce. What's clear is this: we don't just have a workforce shortage, we have a workforce design challenge. And that's what I'm talking about today with our two guests, Trepanier and Ching-Min Chen, two of our task force members who were directly involved and responsible for putting this report together. I'm excited to sit down with them and talk about the framework that they're putting forth, the call to action globally for people to adopt innovative new models of care to address critical shortage, and how technology factors into all of that. So stick around. You don't want to miss this episode. It starts right now. Critical shortage, maldistribution, climate impact, tech readiness, and career mobility. These are the challenges facing global nurses and allied health workers today. We're looking at the numbers, the data, and the research on this episode of From the Bench. Brought to you by TruMerit. Hi, everybody. Welcome back to Care Anywhere. I'm Lea Sims, your host. Today, we're tackling one of the most urgent challenges in healthcare globally, safe staffing for nurses and healthcare workers. But not just from a numbers perspective or from a physical safety perspective. We're exploring what it looks like to rethink how care is designed, delivered, and sustained through new models of care. About a month ago, TruMerit released a report, Safe Staffing Through New Models of Care, and I'm joined today by Syl Trepanier and Ching-Min Chen, who were part of the task force who did this research, put this report together, and developed the framework that we're going to talk about today. So I'm excited to welcome you guys. Welcome to the podcast.
Thank you. Thank you.
Thank you.
It's great to have you here. So let's start with introductions for our audience who may not know you. Syl, if you don't mind introducing yourself and your connection to TruMerit and what you do in your everyday life and how you got connected to this task force. And then Ching-Min, if you could do the same, and then we'll jump in on our discussion about this great report.
Absolutely. So I'm Syl Trepanier, and I currently serve as the board chair for TruMerit. And my full-time job, I'm the Assistant Chief Nurse Executive for Providence, which is a healthcare system based in Seattle, Washington, where we practice in 7 different states, from Texas to New Mexico to California, Oregon, Washington, Montana, and the great state of Alaska. And we have 51 acute care hospitals, and I have the honor and privilege of serving roughly around 48,000 nurses across our healthcare system.
Great perspective. Ching-Min?
Yeah, my name is Ching-Min Chen, and I'm from Taiwan. Well, the reason I got connected with TruMerit is because when I was serving as the board member of American Academy of Nursing, I was introduced to this team. And my daytime job is a dean from a College of Nursing in Taiwan. The name of my university is Kaohsiung Medical University. And I think the reason I was invited is mainly because I'm from Taiwan. The reason I say that is that, Taiwan has been rated by many international evaluation being the best in the world. But we still suffer very severe nursing shortage. So I think it would be great if we can have this point of view from different parts of the world to share how we can utilize this model and to look at how we can, even though our system has been rated the best, but we still need to revisit the system to see how can we input it. Yeah, that's what I think.
Absolutely. Great. Thank you so much for kicking us off. So Syl, I'd love to start with you. You mentioned that you're our board chair. You chaired this task force. There's been a lot of conversation globally about staffing shortages. We hear the phrase critical shortage a lot, but this work really goes deeper than that, looks at the issues from a systems level. So let's talk about what prompted the creation of this research, this task force, and pulling this information and putting this framework together. Why was that an important board initiative, and why was TruMerit the right organization to convene this group and get it kicked off?
How much time do you have? There's a lot. There's a lot in that question, right?
However much you
I
need.
know. So
Yes.
here's where I would start. You know, healthcare is at worldwide is at a very interesting juncture. It's challenged, and in some ways it's a good thing that the industry is challenged. We've always been challenged with supply and demand for the workforce. That's a known fact. What prompted us thinking about this is a few data points. A year prior to us considering putting this task force together, we had just seen, and we participated, TruMerit participated in collaboration with the International Council of Nursing in producing a document in which we estimated and reported that we would be short roughly 13 million nurses worldwide by 2030. It's a pretty daunting number.
It
So
is.
considering
Yeah.
that, it becomes very clear to everyone that it really doesn't matter how good any of us are in recruiting or retaining nurses. The fact is that we're never going to have enough if we keep on working the way we work right now. And that's evidenced by many people who are considering and thinking and experiencing and developing new models of care. We saw an opportunity to develop a framework to help organization as they think about developing a new models of care. What framework should they have in mind in order not to break anything while you're innovating in the moment? And that was inspired by some of the work that IHI had done and others. And in order to do that, we had a few premises. Because of our position as an organization within TruMerit, we felt that this is a topic that we know everyone is struggling with. Therefore, let's put an international table together. And who but TruMerit to do something like that? So we felt it was definitely under our purview. We also wanted to make sure that we address the very important key component that no matter what we do, we need to ensure that we always create safe places to receive and give care. Hence, where we landed on making sure that everyone should have top of mind, making sure that everyone practices to the top of their license, that everyone figures out a way to leverage the entire healthcare team, and also for the framework to be as equally useful for a hospital, a clinic, a home-based approach. We wanted to have a continuum of care perspective into developing our framework, and here we are.
Well, so it's not just about throwing more people at the challenges, right? Or if we even could, to your point, Syl, we could chase that number forever and probably not be able to achieve it. It's really more than a ratio problem or a simple ratio problem. That's what I found compelling about the report. So can you walk, Ching-Min and Syl both, speak to the framework, and let's unpack that first so people who maybe haven't read the report yet would be compelled to go read it after this podcast. You referenced the framework. What is the framework, and specifically what are the three domains, and how does that differ from, say, traditional staffing models that we've seen in the past? So Ching-Min, I don't know if you want to take that first, and then so you can weigh in, but let's talk about the framework.
Okay, I will start it. Well, I think at the first, when I look at this framework, I would say that is quite similar to the well-known and widely adopted Donabellian model, because that also includes three domains. So the first domain is the systems and input. that really set the foundation, because it include rules and regulation. So such as Sylvia just mentioned, licensure, the people's qualification, so we can make sure the person provide care is high quality and with great amount. And also consider the population health need. So what kind of service we need to provide for our customer is important. So they're including prioritized needs, patient engagement, etc. And the most importantly, the infrastructure, such as that we need to adapt the information system, safe working environment that support innovation. So everything need from digital system to workforce model and the learning environment. That's very important. Just I mentioned, set the foundation. That's the first domain. And the second domain is mentioned about the service delivery, is where the care actually happen. So it focuses on maybe interdisciplinary team, hybrid staffing, structural delegation, telehealth support, something that can push us to have high quality care. So I think this is what I call operationalized expression of the system that can work in this place. And the third domain capture the outcomes and output. Here we measure truly matter to the workforce well-being and retention, patient engagement, safety, or cost efficiency and overall value of the health system that probably people will be concerned. So this outcome will finally refine the system and create continuous improvement cycle. So I think this is basically the three domains that will function really well if we basically want to look at how the system is working. Sylvia, is this okay?
Yes, great,
Yes,
great,
yes,
great
absolutely.
job. And I'd love to underscore a few things that she said that really is might add a little color to our listeners in hopes that they will then also want to read a little bit further the report and leverage it as they see fit in building new models of care. At the core of all of this, it's really about completely reimagining the care so that we can have better outcomes, but we can also foster workforce resilience, because this is definitely something that everyone is talking about. She's absolutely right. System and inputs, service delivery, outputs, and outcomes. I mean, that's the backbone of the model. And I appreciate how you highlighted many of the components of that, and I want to underscore three of them. One of them is you talked about the importance of population health needs. I find, I'm going to just use the example of the acute care setting, for instance, as we've, at least in the world I've been in, which is 38 some years now, which has been primarily in the acute care space. Every time we've been in the process of redesigning the work or how we've approached the work, we always tend to approach the work with what we know, the people that we know, the discipline that we know, and we throw this at a problem and we figure it with that. I have a bit of an aha moment over the last few years where this model really helps me is what I think we should do when you're thinking about developing a new model of care and you're thinking about acute care, just to follow this example. First, you should ask yourself, what are the needs, the population needs of your patient, the population you serve on that unit? What are their needs? Not what you do, not the checkbox you check every day, not the activities you do, but you start with what are the needs of this population. It's a very different mindset. That will then drive you on what are their needs? Well, what do I need to do to meet those needs? And who is best prepared to meet those needs? You see, we've kind of looked at it, differently,
Right.
just to kind of offer, one example.
Well, you're talking
Right.
about, do you make people fit for the system, or do you make the system fit for people,
Yes.
right?
Yes.
And that flips the entire
It
dialogue.
flips.
Sorry,
No.
that occurred to me so when you were
Yeah, no,
speaking.
it
Yeah,
does. It flips the equation, and so regardless whether and I just offered an example on the acute care setting, but that fits for anything. It fits for any
right.
care setting. Another output and outcome is around the importance of safety and safety for for the workforce and patient engagement. I worry that for a pretty significant amount of time, we have developed, at least in the United States, we have developed system to meet our needs before it meets the needs of our patients. Like somehow, somewhere, what got lost in translation is although it starts with us, it's not about us. It's really about the people that we care. It's not uncommon, and I could give you tons of examples where we've we stay open in certain places to meet the needs of our providers, to meet the needs of our staff. But does it really meet the needs of the population? I mean, everybody works Monday through Friday, 9 to 5. When are they going to take care of their healthcare needs, right? Uh, we are a 24/7 operation on the acute care side, but when you really think about it, the majority of our resources are not 24/7. They really are driven to a 9 to 5. One has to wonder and ask yourself, who is this system developed for? Do we really have the community needs in mind? And the last one I want to call out is access. There are healthcare deserts everywhere in the world. And for anyone to think that we don't have healthcare deserts in high income countries, name the whole list of them. I happen to be living in the United States right now and came from Canada, as you know. So if you just take these two examples, as rich as they are, there are healthcare deserts. So we have a moral obligation to build models of care that everyone has access to and everyone can afford.
That's a big one. That's a
Yeah, I
big one.
think, yeah, this is really touch me, when we always, let me think about Nightingale, when we are talking about the purpose of nursing is really to help the people, to serve the people, but what's their need? And we always teach our students how to understand the disease itself and how the mechanism and everything, but we have never think about the central need is the person. We are not taking care of the disease. We are taking care of the sick, the person itself. So what's their need? What can we provide? And the final outcome is let them to go back to and retain the health. So this is really a reflection for what I feel Sylvia talk about.
So let's talk about some examples. The report really dives into some real world great examples of innovative models of care that are demonstrating the value of rethinking systems that we're talking about. So, you have obviously one that's close to home, but can you guys unpack a few of the examples or one or two from the report? Because to me, that adds a lot of weight and value. This isn't just conjecture. It's not speculative. It's not, conceptual at this point. These are things these innovations are really rolling out in real time and proving the model, the framework that we're talking about. So it would be great to share an example or two with our audience. Syl, you have thoughts on that?
Yeah, sure. And I won't highlight mine. I will highlight someone else's work. Um, in fact, it's probably a good segue for me to say this. We had the pleasure of having a similar conversation live with members of one of our professional association here in the United States not too long ago. And we were very deliberate because the majority of the audience were United States based healthcare providers and clinicians and the likes and leaders and healthcare leaders. We made a point of not highlighting US based example. in our conversations, because I find that it's easy to stay within your own cultural framework, and that's a lost opportunity when we don't pay attention to what's going on in the rest of the world. So to that end, I want to highlight something that falls under the service delivery, and more specifically around the importance of access to care. So the World Health Initiative, for instance, has worked very closely with the government of Malawi, for instance, and they have, well, in this country, they have very limited access to healthcare. I mean, some people have to walk hours to have access to healthcare. So, what the World Health Telehealth Initiative did is that they bridged that gap by offering volunteer health professional using state-of-the-art technology that was deployed on site to bring specialized services that would not be available otherwise. And so what they had in mind is making sure to treat the patient at the right place at the right time, and deploying that technology. And particularly in this case, this was around caring for obstetric patients, a woman who had delivered and who were having some complications post-delivery, and that really allowed the healthcare workers on site to have access to expertise that they would not have had, that they were now able to treat, and really increasing the quality of life of the woman of that country, for instance. This is an example of one way that you can leverage technology combined with people and knowledge and disseminate expertise in a part of the world that suffers from a healthcare desert.
Absolutely. Technology as a gap bridger in those instances. Ching-Min, do you have an example or one that stood out to you?
Yeah, well, I think I really like an example that's really right now can be applied in Taiwan. The safety, although it's a United States example, the safety stands for sexual assault forensic examination telehealth model, and this is perfect examination that can work together with all these three domains. You know that in many rural areas in U.S. there's not enough trained SANS, sexual assault nurse examiners, and the turnover is extremely high. So what I'm saying is it's really can work here. In Taiwan is that we start to train this kind of person in Taiwan too. So they really laid out the foundation for us. So like the model applied in U.S. in the service delivery domain, the domain try to pair the experienced telesam with an on-site nurse. So during the examination, the remote expert provide real-time guidance, mentorship, and oversight while the local clinician perform the hands-on performance. So this is a kind of hybrid model, just like Sylvain just mentioned in the Malawi model. I think it's a similar one, but it's really reflect exactly what we promote: the interdisciplinary teamwork, clear role definition, delegation, and the smart use of technology. So this is really can be applied into underserved settings. And for the model that written in the U.S. model, the outcome really speak for themselves. 94% of survivors say that they feel better support when the telesam was involved, and the retention of the SAMs jumped to 75% compared to a national average of only 8%. And of course, for the organization, they will save the cost to minimize the turnover and improving the care constantly. So this model is really what I mentioned, the three domains work perfectly. And what I say is especially exciting in Taiwan, as I mentioned that right now we are moving into the similar direction. So our association, Taiwan Nurse Association, has started to launch this nationwide training course for the same. So just starting from a couple of years ago, we are trying to train our nurses to have this competence for examination and evidence collection, this kind of skills. However, in the beginning, we probably don't have enough personnel to deploy to every hospital that require these specialties. But with Taiwan's strong digital infrastructure and a top-performing healthcare system, I think the next step for us is to integrate this hybrid staffing model, try to pairing the local clinician with a remote expert to support those hospitals. They probably don't have the trained SEN. So we can really apply this safety model to Taiwan. So this is the example not only demonstrates the framework in action, but I always think this can be applied globally to different parts of the world too. So I'm really excited to see this can be.
I'm excited that we're talking about it on a podcast called Care Anywhere because this is at the heart. I was just thinking as you were speaking, this is at the heart of what we're talking about on this podcast. How do we enable through technology care to be received and provided from anywhere?
Right.
And so this is such an exciting conversation. And I'm sorry, I didn't mean to cut you off there, Ching-Min, because I thought you were at the end of what you were saying, or I wouldn't have said
It's okay.
that. But,
I'm done.
it occurred to me as you said that. So it's exciting. And honestly, there was so much potential coming out of COVID for telehealth to be more than a stopgap measure, a temporary measure, and to see it really move from its infancy into maturity as a model for creating sustainable hybrid care is very exciting, because I think people could have gone back after the pandemic to, in-person care as usual and put telehealth aside, and to see it being deployed so effectively in both of the examples that you gave is exciting, I think. So you mentioned earlier the estimates that the WHO has put out around the projected shortfall of healthcare workers, 11 million by 2030, and a significant portion of those in primary care and nursing, mostly in lower resource settings. How does this framework that you've both unpacked beautifully here and given great examples, how does that address? Obviously, telehealth will help get us address some of those shortfalls to some degree, but where do you think this framework actually does address shortage and maldistribution? Because that's another thing we could talk about. In many cases, there are enough nurses, they're just not distributed where they need to be globally. So how does this help?
So I think it helps from a variety of reasons, and I'm just going to tease one out. If you think about the three domains that encompasses the model, one of those domain being the service delivery, and within that service delivery, we call out the interprofessional team. It allows us to stop and think for a minute about where are nurses best placed to contribute in that equation, and who else is also best placed in that equation. It's not uncommon that I find myself having conversations with nurses and nurse leader in many care settings. Then when we start unpacking what today we are asking nurses to do, that it's not uncommon we identify a lot of the stuff that they do that quite frankly someone else could do, that doesn't require a license. Now, they happen to do it for multiple reasons. They're there, they've accumulated the activities over the years, you name it. And it doesn't make it right. If we're never going to have enough, we need to use them judiciously, right? For nurses to be practicing to the top of their license, And knowing that there's a big supply issue that's coming our way, it invites us, the model invites us to really truly look at the interprofessional team and beyond professions. What are those roles that we ought to consider, create perhaps, so that we can better meet the needs of the patients? Because remember that one of the dimension also is around the population health needs. So this is how I think the model helps you. It helps you think through, if I'm going to be developing a new model, here's some really key points that I have to at least show curiosity. What does that mean for me? Or what does that mean for our patients? What does that mean for the organization? And is the model that I'm about to do maximizes and at least take into consideration all of the data points as opposed to overemphasizing on something at the cost of something else. That's, I think, what the beauty of using this model.
It also probably downstream or maybe upstream addresses some of the more historically traditional ways we might address shortage. We need to recruit more nurses. We need to put more nurses through school. We need to address transition to practice and all of those things. Rebuilding a system where nurses thrive, are able to work at the top of their licensure, where they have physical and psychological safety in the workplace. That does have an upstream impact, I would think, on recruitment and getting more nurses interested and reinterested in the profession, or perhaps staying longer in the profession than they might have in the past. And I know we don't specifically address that in the report, but as you were speaking, it occurs to me that those two things could go hand in hand in addressing maybe historically how we would address shortage through more people, right? Versus the system. But I think one impacts the other as well. Ching-Min, your thoughts there?
Yeah, it's so true. I think I have similar reflection. So that made me think that maybe in Taiwan, I think the skill mix model really can optimize what nurses, just like Sylvain said, that how can we make sure nurses can work for their full scope of practice so they really earn the back of our nursing value. So just like you mentioned that maybe because of that, we can sustain our nurses to work longer. So this is really what really interests when I look at the model. And the second thing that I also think about, you emphasize new model of service delivery, especially in community-based, digitally enabled care that can expand accessibility and the continuity, as we mentioned, like the healthcare desert that Sylvia mentioned several times. And also in some area, they probably don't have enough healthcare workers. If nurses can work at their full potential as independent practice, they can go there to provide the service that fulfill the need of people's human right. And finally, I think it really highlights the need for supportive work environment. If we really want nurses to work at their potential, then the regulation or relief what kind of limit nurses their full potential is important. So this system is really good that everyone to revisit their maybe healthcare system, or what kind of barrier for nurses they cannot fulfill this kind of potential.
Absolutely. You articulated that so much better than I could. That was great. So let's pivot back a little bit to technology. We've talked about, and you mentioned it earlier, so the need to really focus on population health and what the patient needs, what they need from their care delivery ecosystem and from the people who are providing that care. And also we've talked about, and it's addressed in the report significantly, the role of technology, the role of telehealth and AI. How do those two come together in this framework with enabling that efficiency gain from the technology and without losing that human touch, that connectivity to the patient? Is there a risk of, over leaning towards or overcorrecting toward efficiency at the expense of connection? how do we strike that balance between enabling tech and human connection?
Well, if we pay attention to how many of our professional organizations are reacting to this, I would say we're far from that to happen, because we're probably going to be our own worst enemy in stopping ourselves from leveraging AI and technology. So I'm not so worried about that. However,
Yeah.
I will say that here's one perspective. I'm going to take us back even pre-pandemic. We would have never thought for a minute. Now, we use telehealth in the acute care setting to remote monitor patients, to provide, but we didn't really practice nursing virtually in an acute care setting. It was mostly, at least from my experiences, mostly like a tele-ICU model, which is you monitor things in the background, you call the nurse and you say, you may want to consider this or that, but you really are not caring for patients virtually. We do that today,
More
right?
surveillance, mostly
Today we do that.
monitoring and
We
surveillance.
literally
Yeah.
care for patients virtually, and we do that because of technology, and in some cases because of AI also, that's embedded within the cameras that we have within the rooms today, that actually further supports the practice and offers way much more information to the nurses who are behind the screen. And we know that we can do that safely. We're not breaking anything. The patients are not suffering from that. And in fact, they actually love it. Those who have had the pleasure of experiencing this, because now they have yet one more healthcare players, if you will, to support their care. So, and it's possible to have meaningful interaction with people while you care for them virtually. In our own healthcare system, we've developed virtual nursing, where nurses care for patients virtually. There's at least, in the last 3 months, 5 cases that I can think of where nurses showed up in the room virtually and noticed something was off about this patient and called the nurse to go into the room and stayed with the patient virtually and cared for that person. In one case, with the family member, in another case, with the patient, and cared for them as well as they would have cared for them if they had been in the room and calling for assistance. I'm not so worried about lacking. Now, I'm also not suggesting that we care for patients virtually and nobody's in the room, right? At least not today. I mean, maybe one day we'll have hologram and robots that will be able to do that, that will look like you and I. Who knows?
Star
Maybe
Trek
I've watched
workers.
too much Star Trek in
Same.
my life.
It's the first thing I
Right.
thought of.
But until then, we're going to need some human lives around the patients, but it's okay to have a human life behind a screen to also, care for patients. So that's probably the balance that you were asking about, is don't lose the human touch because you are behind a screen. You can still be a caring nurse, and do it that way.
Well, and it mirrors how we're living now too. So I think about, I have a daughter, I live in Florida. I have a daughter that's in New York City, and I maintain my connection with her through FaceTime. I can't imagine what I would do if I didn't have that technology, or back when people didn't have it. But it seems to me the system begins to reflect the way people are living.
Yeah.
This is not an odd way for people to be communicating. It's what we do. It's what we're doing right now. It's what we do in all of our Zoom meetings. It's what we do with our family and friends on FaceTime. So it seems like that's just a natural way that this would evolve, for sure. But I love your thoughts there. Ching-Min, does that resonate with you?
Yeah, I think Silvio explained this so beautifully. And I think the key word is that the tool is used to enhance, not to replace the human relationship in care. And what Sylvia just explained, let me think about the IND theme just released this week, talking about 7 powers of nursing. And one power is the power of care and the power of proximity. And if we can really take care of the patient, because we can know the change, the very minor change in patients that probably machine will not. That's because we are around the patient all the time. And this AI really help us to not really take the nurses away. It's helping us to free our time to taking care of patient with our empathy, communication, relationship care, rather than pull them away from the patient. That's really something I want to add.
And maybe increasingly it's more about presence than proximity. How present am I with that patient? And to your point, Syl, I've heard a number of and read a number of surveys where patients say they feel like their clinicians are more focused on them, paying more attention in their telehealth visits, because the screen sort of requires you. It forces you to focus in one space, and so it feels more present, even though there may not be physical proximity. So maybe that's something that's evolving as well, which is
the power of
exciting,
nursing.
I think, for people. Yeah. But it doesn't change the presence of the nurse to care, whether that's in person or virtually, and telehealth is enabling that in some really powerful ways. So Syl, just to pitch this last question to you, and then I'll throw out a sort of a round robin question to both of you. The report, obviously, we don't want it sitting on a shelf. It's very timely. The next steps for getting people to really lean in on it, consider how they're adopting it or how they're already integrating it into their care model evolution and innovation. How should different audiences, let's say health leaders, policymakers, educators, use this framework to shape the future of care models? Like, what is our vision for this report? The call to action, I guess, is probably what I'm getting at. Where do you see that opportunity?
Well, imagine a world where you have industry leaders, healthcare policy leaders, healthcare educators sitting around the same table, and consumers of care sitting around the same table and identifying and having a conversation around what the new model of care needs to look like. I think it would be super powerful to have all of the stakeholders using a framework such as this. And oh, by the way, I want to correct myself, because at the beginning I called out IHI in my initial comments, which are always an amazing resource, by the way. This model particularly was really based on the National Academy of Medicine, clinical well-being and primary health care performance improvement. That's who we use, and I want to make sure that I don't forget to say that. So that's the vision. The vision is we're offering a tool and hopeful that we can create, it's a conversation starter. And the ultimate is to have all the stakeholders together in having the conversation to build the healthcare of the future.
So let's close with this, and I'll throw it out to both of you. If you could implement one thing from this framework tomorrow, what would it be and why? Ching-Min.
Okay, you know what? As the example we just mentioned, I think I would really like to apply this to the FNP model that we are really working on right now, because right now we have so many trained FNPs, but they are not allowed to work independently. But with the support here, probably we can, just like I mentioned, we can deploy these FNPs to those rural area to provide the health service for those people. They don't have enough health care service. So as I mentioned that if we want them to have practice, so we need this kind of guideline to have a telehealth platform, clear regulation guideline on their scope of practice, and digital decision support system to support the nurses to work in the areas. So I think with the hybrid model allow FNP to function as a frontline primary care providers, while also remain connected with the interdisciplinary virtual team. I think they can also benefit the people in on-site and also release their tension for our FMPs. And finally, I think this will benefit our patient to improve the care quality and workforce sustainability, and the most importantly, equity for those people. They are allowed to have the health service. So for FMP, this hybrid staffing really reduce professional isolation and support their retention and ensure the psychological safety. All these key components right now probably is the first step. Our FMP should be brave enough to work independently in some rural areas. And I think this is ready to go.
Yeah, a good start. So, what about you?
This work can feel so daunting, and to a certain extent, one might even look at this and think, oh my God, are we trying to boil the ocean here? And I don't even know where to start. So that's why I love your question. And I think that no matter the care setting, no matter where you are, no matter who you are, I would leverage this model, and I would look at it, and I would take a piece of it, and I would probably prioritize the population health needs. I would ask myself, who is my population that I serve? And let's not assume what their needs are. And let's make sure that we're clear about what those are, because that might, I think, showing that curiosity is going to start to bring to light whether we're doing the right activity, and God forbid, whether we have the right team in place to actually meet the needs of those clients. That's how I would start with that.
That's great. That's a great first things first recommendation. Yeah. Start there with where it should begin and end with the patient, with the patient and their needs. That's right. Thank you so much, both of you, for joining me today on this podcast. It's been a great conversation. What I'm taking away from this conversation is that safe staffing isn't just about enough people or more people. It's about designing systems where people can succeed. And we talked a little bit about safety here. It's about physical security, but it's also about that psychological safety. You just mentioned it, Ching-Min. Systems designed for patients and staff to thrive. That's what we're talking about. Thank you both for being here. Thank you for all the work that you put into this, that you are doing, and for helping to move this conversation forward. And thank you to our audience for listening and leaning in. And we hope that you'll go out and read the report. You can find it at TruMerit.org on our homepage or in our research hub. Thank you for joining this special From the Bench episode of Care Anywhere, and come back and see us for the next episode. Thanks for tuning in to this From the Bench special episode of Care Anywhere. You can find TruMerit research by visiting our research hub at TruMerit.org. If you're new to Care Anywhere, you can find all of our podcast episodes, including From the Bench, at TruMerit.org/podcast or on your favorite podcast streaming channel.